Начинаем запись. Мы, конечно, можем подрезать всегда и подрезаем начало, но тем не менее. Вот. Так, у нас всех пустили мы, кто просится. Всех. Антон Кириллович Моисеев пришел, да? Здравствуйте, Антон.
Добрый день, Александр Ильич. Добрый день всем.
Саша Малихин здесь, тоже приветствуем.
Да, Александр Ильич, добрый день.
Да, Наталья Сергеевна Григорьева.
Здравствуйте.
Да, здравствуйте. Ну, просьба, если можно, как всегда, зарегистрироваться в чате. Вот, многие уже сами делают. Ну, я тоже зарегистрирую. Так, вот Белова Людмила Георгиевна. Так, Людмила Георгиевна, здравствуйте.
Да, здравствуйте.
Здравствуй, Люда.
Добрый
Здравствуй,
вечер.
рада тебя видеть.
Я тоже рада всех видеть.
Зарегистрируйся, пожалуйста.
Сейчас пошлю, да.
Вот Жак к нам присоединяется, Жирнов Михаил Игоревич. Hi, Жак. Hi, Misha Жирнов.
Hello.
Hello. Jacques, how are you?
Fine.
Great. Are you at home or?
Fine. I am at home. I am at home today, and well, I had some problems 5 minutes ago, but I think that now everything is okay.
Great, great.
Okay.
Jamie is joining us. Hi, Jamie. How are you? Jamie, do you hear me?
I can hear you.
Yes. How are you?
Хорошо, спасибо.
Здорово.
Может, мы по-русски будем говорить?
Почему что нет?
Будет быстрее. Да.
Ладно, ладно. How is it in Texas now?
It's getting worse in Texas, but I'm 3,000 kilometers away.
Oh, how are you?
So I'm safe on a hilltop in Vermont, surrounded by nothing but field mice and chipmunks, who do not appear to be subjected to the coronavirus.
I see. It's now getting worse with the coronavirus in the States, as far as I understand.
The situation is very bad. It's out of control.
Миша, а как в Британии, в Лондоне? Миша, how is it in London?
Well,
here in London is, well, reasonably well.
Mhm.
So from today on, practically all restrictions have been weighed up. So it's fine, but unfortunately, the news from the countryside is not so good. I mean that in Leicester, they had to impose the same restrictions again. So they had to return to the lockdown practice.
Mhm.
Because
In what
of
region? I'm sorry, I didn't hear it.
Leicester.
Mhm.
So the symptom not very good, actually. Not very encouraging.
Mhm.
What the situation looks like in Moscow?
I'm near Moscow right now, and I just visit from time to time Moscow for a couple of hours, but probably my colleagues will tell you. Here in Moscow region, everything seems to be quite quiet. Yes, yes. Виктор Мейрович, как ситуация в Москве?
Что вы имеете в виду?
Ну, общая ситуация с ограничениями, с отсутствием ограничений.
Никаких ограничений нет. Всё.
Нет, сейчас ограничения довольно слабые в Москве. В общем, уже и парки открываются. И, ну, единственное ограничение такое, что в общественных местах маски надо носить, но многие этого не соблюдают, не делают.
I'm sorry, Jamie, Jacques, you understood what Viktor Meirovich said, I believe, yes?
I actually didn't because my hearing is poor.
Oh. So he said that a lot of the majority of restrictions have been lifted by now. Only such a restriction as wearing masks and gloves is in force in social places. So in general, it seems to be quite all right. But we'll see what.
We lifted those restrictions, not so much masks, which were always voluntary, but the opening of restaurants and bars. And the caseload in Texas has gone up. It's more than doubled. And around the country, I think it's up about 70% over the since the end of May.
17 or 70?
70%, yeah, in a general range. So we're beginning to stress hospital capacity in parts of in Houston, for example, and the situation is really quite serious. There's a lot of political pressure to open, but of course, people open and they open up their businesses. They can't make any money, so it's in some sense a fool's errand. They're going to end up having to. If they don't stay closed, they'll fail anyway on economic grounds. It's very problematic.
Yeah, I see. Sergei Rogov is joining us right now. Just a second, I'll let him in. Yeah. Сергей Михайлович, здрасте. Сережа?
Привет.
Сергей Михайлович.
Привет, Саш.
Здравствуй. Ты под пальмой или нет сегодня?
Нет, я сегодня просто натираюсь на даче.
Вот.
Пальмы
Тут
привет.
лучше. Лучше даже, чем пальма.
Ну, завидовать не надо.
Светлое чувство.
Да.
Okay. Jacques, how is it in Paris?
Well, the situation is now coming back to the normal. We are wearing masks only when we got into public transportations. But, well, some people are wearing masks in the streets, but it's not the majority. And now bars and restaurants have reopened. So even demonstration, you know, street demonstration are taking place. Just one today, a big demonstration going onto the Ministry of Health, of Public Health. So, well, the situation is more or less normal. Nevertheless, the fact is that economic activity is still between 90–95% of what it was before the pandemic. And I don't think that we will recover well, the 100% level, or at least the level of end January before the end of the year.
I see.
They expect the second wave.
Well, it is not, well, you know, so to speak, the second wave. The problem is that more and more people, you know, scientific people are telling us that it could be a seasonal virus like the one of the flu.
Okay.
So it will mean that we will have another peak of the pandemic by November or December. And it is absolutely obvious that we could not go again into the lockdown. The lockdown has cost too much to the French economy. So if we had a problem, we could, of course, reconfine some places, you know, some very precise place, but there will be no more a general lockdown of the economy. We can't afford that.
I see.
Dear colleagues, it's now 6:15 in Moscow, of course. So probably we can begin our seminar. This is the 12th seminar, and I think this is going to be the last one seminar dedicated to coronavirus pandemic. And today we have an opportunity to listen to Tatiana Chubarova. She is doctor in economics. She works with the Institute of Economics of the Russian Academy of Sciences. At the same time, she is our professor at Moscow School of Economics. And as you already know from our last seminar, the topic of her seminar is the health care system, its state, its the prospects in this very field. But I think that she'll tell us much better about her.
Shall I press demonstration?
Yes,
again?
please. You can switch it on. Share your screen. Okay, great. So you are welcome. I ask everybody to switch off our sound right now, and then we'll switch it on after the report is over.
Okay. Hello to everybody once again. Today, the topic of my presentation will be healthcare in times of pandemic. But I would like to stress from the beginning the certain limitation of my presentation, because the topic is very huge. And at this stage, I am not aspiring to prepare a comprehensive analysis. It will be rather a preliminary analysis with some interesting facts, which will probably help you to understand the situation. Usually it's called introduction, introduction to a healthcare system in pandemic. And there are two big limitations to my presentation. First of all, I would like to discuss social and economic rather than clinical and pharmaceutical issues. But of course, I can't go without some epidemiological data. But as to pharmaceutical, so that's a huge area which requires special attention. And it is connected to developing medicine to treat COVID and to developing vaccines to prevent its spread. And today, the problem which concerns the humanity is how to secure access to the vaccines and medicine. And they are discussed in terms of common good. You know, economists immediately recall about public goods. And just recently, just tomorrow, I saw on internet that some of the firms already developed a drug, and the course will cost about $20,000. So that's quite a big money for less developed countries. And the second limitation is that the problem with statistical data, both in terms of reliability and in terms of formality. I mean, under formality is the official statistics. And of course, the main problem today is that countries' methodologies for reporting COVID-19 deaths differ widely. And this causes concern among research community how to do comparative research. Though, as we will see later, some comparative research already started to emerge. And it's still very interesting, taking into account the statistical problems. I would like again to focus on healthcare, you know, as much as I could at this stage. And of course, the pandemic affected healthcare like no other industry, or if we treat healthcare system as a part of societal life, for three main reasons. Because first of all, healthcare is today on the front line of fighting epidemic, and it carries the main burden of epidemic. And of course, we should also mention the high risks for medical staff of being infected by COVID. The second one is that it's becoming obvious that after the pandemic is over, health system will inevitably have to be changed to be able to cope with such pandemic in the future. But the question is still open how. And this question is very, very, you know, important, because as we'll see now, the humanity is very reluctant to draw lessons from its past experience. And of course, the pandemic demonstrates the high costs of mistakes that are already evident in health policy. Of course, we should bear in mind short-term versus long-term consequences of any health policy decisions. And interestingly enough, that the role of healthcare in pandemic is twofold. First of all, we should discuss epidemiological situation. And when we hear about the importance of social distancing, I'm sure that's in all countries, they say that the goal of social distancing is to buy time and build healthcare systems capacity to respond to and control the pandemic. This is the words of the Howard Markel, one of the American scientists. And so that's, you can see that's very popular slide when they show that we need to introduce protective measures. One of the reasons being letting healthcare system time to adapt to a new situation, to build up capacity to treat COVID patients. And so that's the slide. You can see it in a lot of, you know, in a lot of papers on the internet. And the second role is the role directly related to healthcare is just to provide healthcare, to provide cure for those infected. And it means that how health system respond to the situation, both in physical terms. Under physical, I mean just the capacity, like the number of beds, number of doctors, and clinical, meaning if there are any clinical protocols, how to cure, how to treat patients with COVID. And I would like just to make, because there is a lot of data mostly epidemiological, and it's a bit chaotic. So I try to ask some questions to somehow make sense of all this data. And when you look at situation, you see that situation around COVID-19 is a bit controversial, and there are a number of issues quite interesting, and it's not so simple. First of all, we discussed last seminar a lot about social trends and health trends in this context, but are they new? Or we just see that the old social and health trends are somehow highlighted, exaggerated, stressed, some of them becoming more important, the other becoming less important in this situation. The second question is, and it's also quite interesting, how expected or unexpected was the pandemic? Because as we will see a bit later, it could be expected, and just. And this third question is about healthcare reforms, because in all developed, at least in all developed countries, there was a round of so-called modernization reform. And there is a very good Russian saying, "Скупой платит дважды." And I found a very nice English wording for it, penny wise and pound foolish. So let's look at this, trends in a more detail. If we look at the health trends, we can see two trends which coincide during the pandemic. First of all, for a long time, we witnessed in developed countries the increase in non-communicable diseases, which is combined with so-called comorbidity. So when a person have, two diseases, chronic diseases at once. And I use here the OECD data, which is very comprehensive and good. And they say that almost 1/3 of people aged 15 years and over reported living with 2 or more chronic conditions in 27 OECD countries. And one of the most dangerous in terms of complications disease is diabetes. And today in OECD countries, about more than 6% of adult population lives with diabetes. And due to the specifics of this disease, we may say that about 39 million adults have are undiagnosed with diabetes. So that's one problem. But the second problem is that we see recently more cases of communicable diseases. Especially, we are not talking here about such children diseases and measles, chicken pox. We're talking here about influenza. And you can see on the slide the data, that's quite a huge load worldwide. And WHO recommends that 75% of elderly people should be vaccinated against seasonal influenza. And OECD data shows that only Korea meets this target. And in many cases, the level of vaccination decreased during the last 10 years. Especially large decreases can be seen in Germany, Slovenia, and Italy. And here there is a slide, just a quite interesting slide, about the structure of mortality. And you can see the change for the century of the role of pneumonia and influenza in mortality. And you can see that it was, its number of per 1,000 was about 22 cases in 19 and about 16 cases in 2010. And when I was studying in London, I was living, I was renting a flat from a lady. She was from Spain, and she told me a story about her family living through the famous epidemic of the flu in the beginning of the 20th century. So, that's, we will come to this, this problem a bit later. But another problem for me is that stories that talk about unexpected epidemic, which is not exactly the case. And I just want to present you here an exercise, Cygnus, I guess that's the pronunciation, which was conducted in Britain in 2016. So it was conducted in 2016, a 3-day national level exercise to look at the impacts of widespread pandemic and AIDS outbreak on health delivery. And there was about 1,000 representatives of health authorities, health providers of different levels from all around Great Britain. And they discussed the worst scenario. So they assumed that at the point of epidemic outbreak, there was no vaccine. And so they were trying to analyze how the National Health Service would be able to cope with this epidemic. And to say nothing, that the UK has an influenza pandemic preparedness strategy, which was published in 2011. And we can see that it was the consequences of the epidemic, 2009 epidemic, but still in 2016, here are the results. And the main results was that Britain was not adequately prepared for a full flu pandemic extreme demands. And here, on these slides, I'm sure you will have this presentation later and can look at it closely. They listed almost all the problems which we will have by the end of the presentation, including the role of social care, the role of healthcare workers, the role of, the role of managing patients' flow in the healthcare system. But so we can see that as early as in 2016, at least in Britain, health authorities was aware that there, in case of epidemic, there might be great problems with NHS. Another quite interesting fact which I would like to present you is that there is a Global Health Security Index, which is the first comprehensive assessment of global health security capabilities in about 200 countries. And again, you can see that this is a question of epidemic, full-scale epidemic, which was discussed before COVID outbreak in 2020. And this index it's organized around 6 main subjects: prevention, detection and reporting, rapid response, health system, compliance with international norms, and risk environment. And again, the global, the findings was that the national health security is fundamentally weak around the world. No country was fully prepared for epidemic or pandemic. And the average score was only 40 out of possible 100. And more than 100 high and middle income countries do not score above 50. And Russia, you can see at the bottom of the slide, Russia was 44.3 index score, and it was 63 out of 195 countries. And you can see here some of the problems. There was the lack of health work strategy. There was, low score for physician and nurses midwife density. And there was only 11 countries show plans to dispense medical countermeasures during health emergency. So these two, these two facts show that in fact, the discussion about the possibility of epidemic was on the way from the beginning of this 21st century. And here, I can present you a book which I bought at the Moscow book fair, which is, by the way, conducted almost in the midst of pandemic. So I decided to go there to check myself. And I bought this book by, famous Russian philosopher, Stoichkov and Zatravkin. And they have one paragraph specifically devoted to the emergence of new views on the essence of epidemic. And in this book, they stressed that the first quarter of the 21st century will be full of epidemics. And we can see it because on this slide, I just provided a list of some of the viruses which affected mankind from the beginning of 21st century. Of course, there was SARS, there was H1N1, there was MERS, Middle East Respiratory Syndrome, Ebola, Zika. And you can see, so there was a lot of bells ringing for, you know, for people, for societies. But you know that, as we say in Russia, the winter always comes unexpected. So this the same happens with COVID, unfortunately with COVID pandemic. And here I decided to make a small slide. That's the data for yesterday. The data of WHO, because as I've told you, there are different data provided with different agencies, but I should say that it's more or less comparable when you have big figures. And so here you can see the confirmed cases, that's millions, and deaths. And unfortunately, when I was making this graph, you can't see the number of deaths relatively to number of cases. And so I decided to keep the table as well. And so you can see the situation by the WHO region. That's global. Globally, more than 10 million people are infected and about 500,000 dead. And you can see the breakdown by America, Europe, Eastern Mediterranean, Southeast Asia, Africa, Western Pacific. And you can see that that's, you know, the wheel of fortune, the Southeast Asia, which can be considered that the birthplace of COVID, just have much less confirmed cases and much less deaths toll than, say, Americans and or Europe. As to Russia, that's the data also for today, yesterday's data. So that's Russian situation. So we have confirmed cases about more than 6,600. Confirmed cases daily was about 6,700 yesterday. More than 4,000 people recovered. The death toll is slightly above 9,000, and we conducted more than 19 million tests. But here I would like, that's, you can find these figures easily on the internet, but I would like to draw your attention to the relative figures, because mostly people operate absolute figures. But to compare countries, I think that relative figures are more important. And here are the graphs that present top 10 countries with the biggest total cases of COVID-19 per million population. And that's the blue graph, and the red one, you can see the total deaths of COVID, that's 1 million population. And you can see Russia, it's, if the situation is not so probably dramatic relative to other countries, if we calculate relative figures, and the Worldometer, the one of the sites, gives it for 1 million population, and again, the total deaths, because the absolute figures, the United States are leading as absolute figures, but you see is when we have this recalculated per 1 million, you can see that UK and Spain, Italy have much less, much worse situation. In my presentation, I have some of these, actually have 3 parameters. That's total number of cases per 1 million, the deaths per 1 million, and number of tests per 1 million. So probably I will not show you all these slides. They are in my presentation. We can come back to it later. But probably I would like to focus on a group of countries in a group of countries, Central and East European countries, because of course, people and researchers and journalists and public administrators, they all try to find factors that influence the parameters of COVID in the various countries. And here you can see the data for Central and East European countries. That's for total cases per million. The yellow is deaths per 1 million population, right? You can see Russia, that's on the third position here in this ranking. And you can see the number of tests conducted Russia per 1 million population. Russia is here the leading country. But what is important is that some of the researchers noted the staggering difference in birth rates between Eastern and Western Europe caused by COVID-19. And here I presented some of the reasons, some of the factors that are cited in the recent research that might be used to explain such a situation. Of course, people stress that East European countries just adopted quite serious social isolation measures. And one of the reason it is cited in the literature that probably there was a fear that the healthcare system in these countries might be overwhelmed by the virus, and social distancing will help to save a healthcare system from overload. Two more factors which are used, that's urbanization and population density. They are also used in the research, but still they considered controversial as no consistent evidence is provided how they influenced the pandemic. Another factor might be the number of citizens that reside in nursing homes, because in Western Europe, their numbers are much bigger than in Eastern Europe. And we know quite well that once the virus enters a nursing home, the consequences are very bad. Surveys shows that residents of nursing home account to about 40% of all diseases in Belgium, 45% in France, 53% in Italy, and 57% in Spain. One more speculation, which is quite popular now, that's the compulsory anti-tuberculosis BCG vaccination program across country. But again, one study was cited which find correlation with this vaccine, but still WHO state that there's no sufficient evidence to accept this proposition. And there is some research underway in Germany and Netherlands on this issue. And there was one more factor which I don't understand. Maybe somebody will understand it's too medical, but you know, it's sometimes also cited in studies trying to explain different epidemiological situation in all around the world. It's some receptor polymorphism or whatever. But still, people think that probably the delay infection and timeliness of measures may better explain in many situations low COVID morbidity. But in my presentation, I try to avoid social distancing and all these measures because we already discussed it in our previous seminars. So that's BCG vaccine. That's a slide. If you are interested, you can have a look at this, idea. Jean Sato claimed that there is a correlation between such vaccine and mortality rates. And the countries which abolished mandatory vaccination have bigger death tolls than East European countries, which traditionally from the Soviet time have this vaccination. And again, this contribution of East Germany may lower the total death rates for Western Germany. Another factor might be the age of male population. The older the male population is, the higher the mortality rate. But the two countries with the highest proportion of older men in the population, Greece and Japan, were able to maintain a relatively low mortality rate. And in one of the articles, the Greek authors give an explanation to this, that the Greek authorities have put in place strict measures on time, while citizens aware of the fragility of the healthcare system remain disciplined. And I have some friends living in Greece, and when I was in touch with them during the pandemic, that's exactly what they told me, that look, our health system is so weak, so it won't be able to go cure all of the COVID patients in case of an outbreak. Of course, some people talk about cultural differences, about mentality in Eastern European countries which lived under authoritarian regime, which made citizens in the East more disciplined than those in the West. And in one article, they also said, yes, while Poland was closing down and quarantining everyone crossing the border, in Germany, people were simply told to wash their hands regularly. So cultural differences in some studies also are considered as a factor of lower COVID mortality in East European countries. And there was a very recent research on hospital beds. Is there any link between mortality and hospital beds? So I should say that it's a very interesting question, because I myself, with the help of my colleagues, we tried to make a very simple comparisons between mortality rates and hospital beds. And unfortunately, we didn't find very simple, straightforward, relations between these two indicators, though in some countries, say in Italy and in Spain, the number of hospital beds is twice less than in Germany. So we may speculate that they somehow cause the difference in the death rates. However, I came across a study of Nathan Sussman. You have the reference here. You may have a look at it. And he analyzed cross-country evidence to find if there is any impact that hospital beds may have on mortality. And he used the data from 66 countries. And he considers hospital beds as a good measure. It's a good measure in union which captures the overall capacity of the healthcare system, because to the bed you attach, hospital equipment, you attach staff, and they are connected with intensive care units and etc. And also, because we were doing just very straightforward comparison, just having beds and death rates, he made some econometric calculations and control for different factors. For example, age, population age, the share of population elder than 80 years old, urban factors, and he took the role of the state in the economy. And so, controlling for all these factors, he came to the conclusion that the number of hospital beds has a significant impact on mortality rates. And therefore, he urged his policymaker to do something, especially countries which have poorly developed medical infrastructures. He advised them to increase the number of beds immediately. However, when we talk about mortality, there's still a big statistical problem. It's widely discussed because there are countries use different methodology to calculate death toll. And here I just want to remind you a very interesting, if I may say so, fact. That the Financial Times, which has a very good site following the COVID outbreak, they alleged that the way mortality is registered in many countries is not reflecting properly the mortality rate. And so they suggest that the mortality should be measured by excess mortality, meaning the number of deaths over and above the historical average for the same period. And according to Financial Times, The overall deaths rose 60% in Belgium, 51% in Spain, 42% in the Netherlands, and 34% in France during the pandemic compared with the same period in the previous year. And of course, some of these deaths might result in causes other than COVID, especially foregone treatment. But they pay attention to the fact that this excess mortality is more in countries which are worst affected by the COVID. And here, unfortunately, Russia also feature in this report. Also, I would like to stress that not only Russia were criticized by the Financial Times. And what they do, they use the official mortality data provided by the ZACS. That's a special agency where people register deaths, births, and divorce, marriage. And they took data for April. It's open. You can also check. It's open on the site. You can find it on the site. They checked all-cause mortality data in Moscow and St. Petersburg in April 2020 and compare it with the historical average of the previous year. And official COVID deaths were, at this period, officially registered 629 for the same period. And so they calculated that there was, if we add this excess, the excess deaths, to then the Russian national death toll might be, at least for Moscow and St. Petersburg, for 1 month, might be 72% higher. Of course, this publication did went unnoticed. There was a big row, and the Russian Tatiana Golikova, our vice prime minister, was kind of explaining the situation. And the situation is actually quite simple, because what we do, we register, we use a registration system which is based on the main disease. I know that in some countries, say in Italy or Spain, they calculate any people having COVID as COVID patient. In Russia, no, they took only, they register as COVID deaths only people whom they consider to be dying of COVID, not of other diseases. That is why probably the death toll is lower in Russia, but I should say that it's quite a legitimate way of calculating this. There's nothing, you know, illegitimate there. And probably here, I would say that the role of WHO could be more active, because it would be very, very important for research and for future planning to have a good comparable data on mortality in during the COVID pandemic. And if we come to health system in Russia, when I was making this slide, I must say to you that I become quite bored, because there is a lot of information in Russian health system, and some of it is also provided by our institute. So the problems of health system in Russia are well documented. And probably for our case today, what is important that we have very low public financing and quite low total financing as calculated by WHO, just 5.5% of GDP. It's a well-known fact that the number of hospital beds was decreasing, and including the number of beds for communicable diseases, they were decreased by more than 2 times. And also the number of epidemiologists and infectionists, doctors decreased quite substantially. And so the problem of Russian healthcare system are quite well known. But what is important for us, how health system reacted to pandemic, because as I mentioned earlier, not only Russia went through so-called modernization reform. In many Western European countries, we also see some, you know, similar developments. Probably Russia was a bit lucky, because we start decreasing from a bigger numbers, and so at the end, even if we have such a big decrease, we still have a bit bigger number of hospital beds than in Western European countries. And key measures to respond to the pandemic might be summarized around 4 main issues. First, just to ensure access to diagnostic and treatment. To strengthen and optimizing health system capacity to respond to the rapid increase in caseload. To introduce digital solution and data to improve surveillance and care, and to improve research and development for accelerated development of diagnostic, treatment, and vaccines. And on this slide, I just make a summary and inventory of measures which were taken in Russia, and they only relate to healthcare system. But unfortunately, I should say that there's no, I failed to find a comprehensive list, official list. So I took most of this data from research, from periodicals, from some of government official statements, and so we can see that the similar responses were undertaken in other countries as well. First of all, the main measure was to boost and optimize space in healthcare facilities. So more beds were deployed in regions, and a lot of federal medical institutions were involved in treating patients with COVID. There was some money were allocated to regions from federal budget, and also the regions received some help in terms of equipment and ambulances, for example. About more than 360,000 medical workers were working with patients with coronavirus. In medical facilities, in medical services, they constantly were developing and updating guidelines how to diagnose and treat the COVID patients. We see the increased production, procurement, supplies of mechanical ventilation devices, of medical devices, and there was about 40 types of medical devices undergo state registrations, which was made simpler. More than 242 million rubles were allocated to Russian public movement of volunteers in the field of health. And healthcare providers, healthcare services will be compensated for income loss to the reduced services which they provide on compulsory health insurance due to coronavirus. Here, just a case of Moscow, because Moscow is always on the press, and it's understandable because at the beginning, the Moscow was accounted for a larger share of people infected and people who died of coronavirus. Now the situation is changing, so the share of regions are bigger than Moscow. But here, what I can see from the press, that in Moscow about 30,000 beds additionally equipped for patients with coronavirus. And in 31 medical institutions belonging to Moscow and 23 federal institutions, and there was 78 buildings involved in this. And there was 3,000 places in temporary hospital and 20,000 places in already existing medical organizations. And also to accommodate more patients, in Moscow, some exhibition pavilions or stadiums, for example, the Ice Palace in Krylatskaya were, and some pavilion in VDNH were turned into hospitals, so was it a big and expensive work was conducted. In Russia, there was one specific feature. I don't know if it's somehow in other countries, but we have traditionally very developed military medicine. And so, of course, the Minister of Defense couldn't stay aside in such a situation. And the Minister of Defense, they built 16 multifunctional medical centers, able to accommodate 1,600 patients, and the budget allocated more than 80 billion rubles from reserve fund to finance this construction in a number of regions. And you can see on this slide that it's quite huge resource. The medical staff, 400 military doctors, a lot of nurses, and more than 2,000 people were involved, both military and civilian personnel, in providing care to COVID patients. One more problem which is important in healthcare and which is discussed in healthcare is protecting medical staff. That's also an international problem. And here in Russia, we have three major streams. First of all, there was increased insurance guarantees for doctor, nurses, and ambulance driver. So if they contracted, they were infected by coronavirus, depending on the loss of working capacity, temporary or permanent disability, there were quite a big amount of money, just up to more than 2 million rubles in case of permanent loss of working capacity. Again, in April, June, additional payments ranging from 25,000 to 80,000 rubles per month, depending if it's a nurse or a doctor, were paid to medical workers who were working in contact with coronavirus patients. And again, there was a system of psychological assistance to doctor, because in many studies all over the world, people stress that doctors and medical staff being on the front line of fighting coronavirus experience a lot of stress, and they need not only financial and moral, but sometimes also psychological support. So coming closer to an end of my presentation, here I just try to summarize health system problems which health system faced during and still facing COVID-19. And they are based both on Russian and international experience, because it's not surprising for me that the problems that health system faced are quite similar. First of all, healthcare, the supply of health services is constrained, and the problem is how to deal with it when there is an unpredictable and fluctuating level of demand, and when high number of patients arrive at hospital at the same time. And so what becomes important, and this problem is still discussed, that how to regulate patients' flow, not only COVID patients, but patients who needed treatment, those patients who do not have COVID, who are not infected, how to treat them in one or in separate facilities. So that's very important problem, which is still needs to be solved for the future, because the research shows, though it's a kind of survey and qualitative research, that people, on one hand, people are not turning for care because they are afraid of contracting coronavirus in medical facilities. And on the other hand, there are problems for people who needed urgent treatment, not coronavirus treatment, to get this treatment. And in some cases, such delays, inevitable delays in such situation might be detrimental to their health. So that's one big problem, one big issue. Another problem is geographical distribution of health services, because it turned out that average numbers sometimes hide a quite severe geographical distribution of health services, and which turned out to be important in providing quick access to health care. Another problem is where to treat patients, in hospital or at home. And again, that's a problem of diagnosis as well, because according to WHO data, about 30% of patients require hospitalization, required to be needed to take to hospital, and only 5% need an intensive care unit. And so that's also an important issue, how to organize home care for those with COVID patients. And again, the role of outpatient care, in our words, the role of polyclinic ambulatory care should not be underestimated, because as experience show at the time of pandemic, everyone is interested in hospital, how hospital works, if there are a number of beds, and less interest is devoted to the ambulatory outpatient care. Important problem which also was highlighted during the pandemic, that's the, as I may say so, public-private partnership, the role of private sector, and the necessity to mobilize private sector facilities in order to provide COVID treatment. That's a also not so simple problem, because not all private facilities were ready to cooperate. Though I know that, for example, in Britain, the NHS contracted an agreement with private providers, so they treated NHS COVID patients. So that's how to manage, how to make relations with private and public sectors. The pandemic is also important. In Russia, also some of the private networks, including, for example, MedC, were providing care, but the great dispute was the following, because they treated for free patients, delivered them as patients of compulsory health insurance, and at the same time they treated patients who came there, for fee. And so, how to make this, justice, how to judge the situation from the point of social justice, still remains open. And again, the lack of protective equipment such as masks, face shields, and hand sanitizer. And as far as I know, that that there are talks about, in many countries, about creating a reserve of such equipment in case of epidemic. 2 words about health financing. So there's 3 main problems: that insurance sufficient funding, and there is of course evident need to increase public funding. I found only one figure in Russia. It's about early May. I think there was somebody from the government said that there will be 500 billion rubles to support healthcare, including beds and medical staff. And I calculated at about 15% of the 2019 health budget. Second one is removing financial barriers, especially in countries where the private financing is high. And here there's a very good American example about diagnostic testing, which should be made at no cost to patients. And of course, we see the expansion of international aid. And there are 2 big organizations, the International Monetary Fund and the Global Fund, which provide financial assistance to member countries to help them to cope with pandemic. And to finish my presentation, I would just like to mention that the health system development vectors, which we witnessed, which we saw before the pandemic, was somehow in contradiction with the vector which are required if we want to find such large-scale pandemic. And here I can only remember about the Semashko model, the Soviet model, which was recently very much criticized by its opponents on the following ground. They say, yes, Semashko model was very good for infection diseases, but it's not so good for chronic diseases. And so now we have to find some model of healthcare which would enable us to combine both individual, treatment and some issues of public health protection. And so here on this slide, I just listed some of the, contradictions which are still existent in health system, and which are highlighted quite evidently by the pandemic. And I would like to point you also to the last point. So again, if we want to realize in the health policy the public concern, probably we should stress public administration, more than business management in healthcare, which is the latest tendency. So thank you very much. I'm sorry for being so long, but it's English and I have to talk a bit slower than I usually do.
Thank you very much, Tatiana. It was great, very interesting, and a very detailed and professional presentation. So now, colleagues, you are welcome to put questions, to make comments. Please let me know who is ready to come in discussion.
Let me ask a question.
Yes, please, Viktor Mirovich.
Yeah. Thank you very much for a lot of interesting material. I would like to say that to evaluate the real costs of COVID-19 for a society, we have to know the level of health worsening of the people who were infected, even if they survive.
Mm-hmm.
What do you think about it?
Okay. Yes, I totally agree with you that unfortunately at this stage probably that will be the next step. At this stage, people are mostly concerned with, containing the epidemic, and I think that that's the next question which will arise, and there will be studies. At this point, I didn't come across any study which used this approach. But what is evident that and there are signs of it, that you are right, that people who survive COVID, even in the form without symptoms, may later have some health complications which need to be evaluated using the scales to evaluate their quality of life. But at this stage, I think that there's no studies like this. At least I know of.
Thank you.
So maybe we pioneer it. No.
Okay.
May I ask a question?
Yes, please do, Mikhail Fedorovich.
Well, there is one thing that I think we must also evaluate, and it's collateral damage from the epidemic. And the damage is not only economical, but it also concerns the death rate. Because while the healthcare system was fighting the epidemic, it refused to provide assistance for patients with chronic diseases. Some of them are quite grave, such as cancer, heart condition, and others. So some of the clinics just declined to receive them and to provide assistance to them, and some of them died. So we need to add this up to the number of those who were victims of the epidemic. Don't you think so?
Yes, you are quite right, and I have it on one of my slides on the healthcare. I put it in the healthcare problems. Yes, that's a very huge problem, because people were not having treatment for two reasons. Because some of them were just afraid to go, were staying at home. They didn't want to go to seek care. But another problem is that some people do really need care, but they are not provided because hospitals are closed for COVID patients. And I know that there is in Russia there were discussions, but it's not come to a conclusion somehow. There was a discussion how to organize the treatment of cancer patients in polyclinics. Okay, so it's a huge problem, and it needs to be solved now, because if we have one more pandemic, we should very well regulate patient flow, so such things can't happen. So that's, I fully agree with you. So that's one of the problem. But I'm not sure that this death will be somehow officially acknowledged. But I think that probably using excess mortality technology of Financial Times, a bit later we can evaluate more or less the number of this excess mortality.
But the problem is that they're not going to die during the epidemic. They will live for a number of months.
Yes,
but their life expectancy is shorter than it might have been if they received proper care. That's the problem, because they might die in a year after now.
And
from
already,
now.
and already we have this case with this volunteer girl who died of cancer.
Yeah,
That's
right.
the case of a deferred treatment, because she was diagnosed too late. Maybe if she diagnosed in March or somehow, it would be something.
And as you know, our own central clinic of the Academy of Sciences is now also giving assistance to COVID patients rather than to ordinary patients.
But again, that's I can't, how to say, if we treat the situation objectively, so I can't blame probably at this stage health authorities for this, because I myself cannot suggest at this stage how it's better to to regulate this patient's flow to avoid such a situation. So there probably this question needs to be addressed specifically somehow.
I heard not once that during the war it happened so that mortality rate from diseases was diminishing because it was a kind of a reaction of population to that danger. I mean, war. Isn't it, or couldn't it be a case here as well? So that, of course, people have other diseases, that's quite true, and some of them are necessarily victims of this situation. But in general, isn't it so that so we somehow concentrate on one target and probably for a limited period of time, but other dangers become not so important as they used to be, or this is nonsense?
I think that's a good point, but it relates to my last sentence about public administrator and business management. So for many people, first of all, for many people, the COVID is not how to say so evident. So during the war, that's all society was involved. But as to COVID pandemic, some people still think that there's no such thing as COVID, that it's propaganda, that it's not that serious as it, described. And there are a lot of, internet connections between people discussing all this. And I think that probably in such a pandemic, it won't be the case.
Okay, thank you. And I know that Anton Moiseev raised his hand and somebody else. So Anton, you are welcome. And another participant who raised his hand, please tell me who are you, and you'll be the next.
I think it was Jacques and James also.
Jacques and James, great. So Anton, you're welcome.
Thank you. I have a double question. So the first question is about the readiness of humanity for pandemics. There was a slide where you have shown that Russia has 44 out of 100 rating, and many countries have about 50. Yeah, so they are half ready.
Yes.
I suppose, and I don't know about this, but I suppose that the cost of increasing this rating is exponential, because first you use cheaper solutions, then you move on to more expensive solutions, so it should be exponential. So the first question is, how much does it cost to reach 100? Is it possible at all? Mm-hmm. And does it really go come up exponentially, or is there a line? So, and the next question is connected with this one, but it's on more global level, maybe. Do you think the future pandemics will be met with the same response of closing down the economy for a few months and then reopening it? In this way, we won't have to relocate our resources from other directions of spending, like from defense, education, economy, or else to healthcare. or there will be a grander response to these pandemics. So in preparation for the next ones, a bigger part of national budgets will be relocated towards finding vaccines, towards creating reserves in defense, these suits and masks and everything, just for them to be lying in stores, ready for the next pandemics. Or do you think the reaction of the current governments was that we have managed this well, we have enough reserves, so next time we'll do the same? Thank you.
Anton, thank you very much. So very, very good questions. And we also discussed them among ourselves. As to the index, I'm very sorry, I'm not that good knowledge about this index. I can only tell you that the countries which scored more were guess which countries? That was United States and UK. So again, so we can treat this index with caution, but why it's important and why I put it on slide, that it shows that, there were some concerns before the pandemic based on the previous, epidemic which I mentioned. And of course, you raise a very important question because it all costs money. And I can understand health administrators. Imagine what shall we do? Shall we keep all these masks somehow? Where shall we keep these beds? I mean, that's a very, very simple, a very primitive question. In what, buildings we should, deploy these beds? So that's very costly. And so it's not by chance that countries are decreasing number of beds because they are quite expensive. So that's a lot of economic issues, but I hope that they will not they will not overcome some social consideration, but again, we live in society, I mean, if I may say so, in the capitalist society. We know that it's a short-term strategy prevails over long-term one for certain reasons. So I'm afraid that probably mankind will not have good lessons out of this pandemic as well. Though I also should stress that the previous pandemic, they were of course less in terms of death toll and in terms of damage inflicted. And my thinking is that the social distancing will not work next time. And recently we have somebody from Brazil with a very good example. He told us that in Brazil, which is a federal state, they introduced social distancing at once in all states, regardless of the epidemiological situation. 1 month, people stay only 1 month. After 1 month, it's over. People just don't want to be, to stay at home anymore. So I think that it's not a good measure to hold epidemic. So there are a lot of very, very important issues, and I hope that they will be somehow, discussed together. So maybe that will give some solutions to find a compromise between all the measures. And of course, that's a problem of drugs and a problem of medicine and vaccination. That's a very huge problem. A lot of money involved. A lot of talk about making them accessible to all people, and when I saw yesterday this $20,000 per patient on this drug, that's quite a lot of money in any healthcare system. So vaccination, that's a kind of very, very interest loaded area. So it also need to be somehow monitored. So I hope there will be lessons, but the previous experience showed that no lessons are derived by mankind.
Thank you, Jamie.
But you can have, Anton, you can have this index if you're interested. It's on the internet.
Jamie, you are welcome.
Sasha,
Thank you.
I also want to comment later, but I want to show several slides. I sent them to Ekaterina Zavarzina. Is it possible to use them later?
Sergey, you asked about the possibility to use this presentation later.
My slides. Я послал несколько слайдов, которые хочу использовать в своем комментарии.
Сейчас, right now.
Попозже, после других.
Okay, so now, Jimmy, the floor is yours.
Thank you. Well, the first thing I'd like to say is thank you very much. And this was extremely useful. I would very much like to have a copy of the presentation so that I can look particularly at some of the comparative graphs at some point. Just a few observations based on, and I think complementary to what you've been saying. I think one of the things that became clear early on was that actually hospital beds were relatively easy to add. You can convert stadiums, you can do, as you were saying in Moscow, ice arenas or whatever it happens to be, and create those facilities, and they were done very quickly. In fact, all hospitals in China were built in 10 days' time. Getting other equipment, ventilators, ICU units, things like that's a bit more difficult. And actually, most difficult thing appears to have been getting personal protective equipment, which needed to be available on a massively greater scale at a time when the global supply chains broke down. So just in some sense, those interesting questions of how to manage what's difficult and what's easy and this relatively easy in the supply chain. On the question that Sasha was raising about health, the fact that people came out of work and they ceased commuting and it did, in fact, it seems, improve health in a lot of respects. And there were fewer accidents. There were no work-related accidents because workplaces were shut down. And there were fewer other forms of contagious diseases, so fewer respiratory diseases, because when you broke the transmission of the coronavirus, you broke the transmission of lots of other things as well. And probably fewer stress-related incidents, such as heart attacks, on people who were maybe already vulnerable to that, but the fact is they were not being stressed so much on a day-to-day basis. One of the things I'd want to ask is whether in other countries there is some sense that early on over-treatment, that is to say, aggressive use of ventilators may have contributed to excess mortality in the treatment, simply because it turns out that very few people actually survive being sedated for many days on end in order to have their breathing assisted. That the mortality rates were much higher than the effectiveness of that treatment was much lower. And I wonder correspondingly whether it's possible that in countries where the health systems were considered to be weak, people stayed away from the hospitals, and that may have improved their chances of survival, because they didn't get put onto treatments that were essentially life-ending, as it turned out. So I just wonder about those things and one final observation about your point about social distancing. It did work in China, worked in Taiwan, worked where it was done, and you said in Eastern Europe very quickly, where it was implemented very fast, worked in Greece. And the problem is that having it failed someplace like the United States, or then all these infections will come back, and you can't maintain it indefinitely. And it's very hard to maintain closed borders and the inability to keep this thing contained inside a country that isn't containing it effectively. So it seems to me that one of the things that we might discover is that the one thing that actually did work will not be sustained, because if it fails in some place, and it does fail in some places, then it won't succeed anywhere in the long run, unless the pandemic somehow fades away for some other reason.
Thank you. I agree with you about this equipment stuff and this supply chains. And of course, yes, research people mentioned that, of course, the traffic accidents and the occupational accidents are down, so they contribute to, better death rates. As to the treatment, that's a very good question. Unfortunately, I don't have any any clear answer to this, any valid answer. I only know that one of our, this Kommunarka, this famous Russian hospital, one of the first to treat COVID patients, its head doctor mentions once that 1 out of 5 persons survived this ventilation. So that's, I think that's quite a huge figure. And unfortunately, as far as I know, at this stage, they are somehow experimenting because they are using different strategies. For example, this plasma stuff, when they took blood from people surviving COVID and infusing it into the people still being under treatment. So I think that's a good point. We should not leave it, we should take it in mind. And the second question was, I forget the second question. I'm sorry. The second
So it's
question.
just about the fact that social distancing works, but it's not sustainable if it fails someplace.
No, that's about seeking care or not. So that's also a quite, people are social creatures. It's very difficult to deal with them. But that's how to say. You mentioned this also very good stuff about people not seeking treatment in hospitals and having better survival rates. So that's on one hand. But on the other hand, when you live in urban area and you have you are in serious conditions, so you have more chances of survival, because usually it's in rural areas where people stay home and are not seeking care even for COVID situation. But social distancing, that's that's also very good question. But I don't think that people will survive it for the second time.
Yeah, I agree. It's very hard to do it a second. Very hard to get people to buy into it a second time if it wasn't made to work and demonstrably succeeded the first time around. I think the Chinese can make it work, and they are making it work because people have confidence in the technique. That's possibly not true. I think it's increasingly untrue in the southern United States. People don't have confidence in the technique. They're not going to observe it.
Okay, thank you. Jacques Sapir was mentioned as a man raising his hand, but I don't see him. Jacques, are you with us? Would you like to say something? No, I believe that he's not. Sergey, Екатерина Павловна, Денис, are you ready? Вы готовы?
Александр Дмитриевич, я отправил в личное сообщение Сергею.
Нет, я пытаюсь завести, у меня что-то он меня отфутболивает куда-то.
Я, наверное, должна остановить тогда, нет?
Да, вы, наверное, остановите.
Ну да, у нас только один человек может одновременно показывать презентацию.
Да, Таня.
Я нажимаю остановить. Окей? So I press stop. Окей?
Yes.
Да.
Ой.
No, it's okay.
Я нажал демонстрацию экрана, у меня что-то не получается.
Сергей, и просьба погромче, очень слабый звук.
Получилось.
Вот, да.
Слышите меня?
Да, вот так говори громче. Да.
Сейчас я еще поближе подвину. First of all, I'm very much impressed by Dr. Chubarov's presentation. It's an excellent discussion. And I want to add another dimension. As you know, my personal interest is how much the present crisis influences the international system.
Louder, please, louder.
More loud? Louder?
Yes. Even more loud.
Oh, буду кричать.
Okay.
Now you can hear me?
Yes.
My interest is how much the present crisis will influence the international system. And the first slide demonstrates what I consider to be the hierarchy of major centers of power in the present international system. You see three major powers which make the top level on GDP, on export, on research and development, and defense expenditures. And then that's US, China, and European Union. And then India, Japan, Russia, United Kingdom, and Brazil, which make the second level in the international hierarchy before the present crisis. Now, the next slide. This is the data which I downloaded yesterday. As you could see, here are the number of confirmed cases, and confirmed cases per 1 million of population, the number of deaths, and the number of deaths per population. And finally, the Global Health Security Index, which Tatiana mentioned in her presentation. As you could see, number one in Global Security Index is the United States. But when we look at the numbers, whether the sheer number of people who got sick and the confirmed cases per population, the numbers are not impressive at all. And when we look at the death numbers, we can see that it's not the United States which is number one. Among those centers of power which I mentioned, the United Kingdom is number one, then Spain, then Italy, then France. And look at the Chinese number, just 3.3 per 1 million of population. And that's in a situation when the health index of China is only 48.2. Now, that's the health expenditures. The red column, that's the medium for the Organization of Economic Cooperation and Development. And as you can see, the highest percentage of GDP is spent by the United States, 17%. Here come mostly the European countries, and that's another dimension. Health expenditures as a percent of the GDP, with the United States definitely leading very much, followed by France, Germany, Japan. And we could see that Russia and China are at the bottom of the list. Now, that's health expenditures per capita, which may be relevant when we think about the consequences of the pandemic. And definitely, here the huge expenditures by the United States, more than $10,000 US per capita. The average for the OECD is about 4,000. When we look at China, it's less than 700. And that's health expenditures per capita in international dollars. Now, this is the response of major centers, major countries to the crisis. That's how much they spent in the last several months trying to stop the crisis. The black circle is demonstrating the expenditures during the previous financial crisis of 2008-2009. The blue circles demonstrate the present expenditures. For instance, you could see in Germany, it's unbelievable, 33% of the GDP. In Japan, it's 21. In France, in the United Kingdom, United States, it's more than 10%. And what will be the outcome? This is the table which demonstrates huge jump in the general government gross debt. As you could see, for the United States, it will be more than 130%. We look here pretty small for the reasons well known, but Russian government's gross debt is less than 20%. Among the developed countries, France, UK, the Euro area is almost 100%. And here comes the last slide, which demonstrates how much the economies of those major centers of power have been hit by the present crisis. We could see that practically everybody is going to experience quite impressive reduction, fall of the gross domestic product, with only one exception. It's only China in this list, which is not in the minus. China is expected, and that's the latest June this month prognosis by the IMF. China is expected to grow for, well, modest 1%, but still grow and not fall. So what I'm trying to say, first of all, amazingly, there is no positive relationship, a strict relationship between the expenditures on the health services and the casualties which have been delivered by the coronavirus. In particular, this slide demonstrates that global security, health security index, like many indexes of this type, could be misleading, because the leader, the United States, and then those countries, developed countries which follow it, are not doing well at all during this crisis. And their response, as the numbers concerning the gross debt demonstrate, spending more money, but it may help to prevent the depression. But will it help to stop the pandemic? And finally, everybody lost. If we look at all those tables, every major power lost as a result of the coronavirus attack. But China lost less than everybody. And that means that in relative terms, the Chinese position in the international system will continue to grow compared to the United States, the European Union, and other centers of power. I maybe diverted the attention from the excellent presentation made by Tatiana, but I think those numbers which I demonstrated prove that there are certain contradictions, that the problem is not resolved by simply pouring more money. And as Tatiana quite correctly said, much depends on how health services analyzed and managed. Thank you.
Thank you very much, Sergey. It's very important, I believe, what you said. So now the floor is Tatiana. You are welcome to make your comment.
Yes, thank you. Thank you very much for very interesting, addition, because we also tried. I totally agree with you, because we also try to find the simple relations between this and not only we take per capita expenses. We discussed public expenses and total expense, and then still on a big number of countries there's no direct relations between finances and death toll. So yes, there are some other factors that should be considered, in explaining this situation.
Maybe the problem is American preoccupation with the so-called means-tested approach. That requires a huge bureaucratic machinery. And as a result of it, while the United States spends, by the way, the government of the United States spends more money on health than even European countries, without counting the private expenditure. Altogether, it's almost 17% of the GDP. But those huge government expenditures, because of the means-tested methods, produce very, very twisted results. It does not help, in particular, those who need help more, like racial and ethnic minorities, blacks, Latinos, etc.
It seemed to me that Jamie, at his very first report, he was tackling the problem of the healthcare system of the United States, and he talked a lot about its demise in this pandemic. You know, I was quite, you know, once in New York, I traveled by subway, and I was just reading one of the advertisements there, and I was struck by what it was written there. It was saying, if you feel that your doctor sends you to unnecessary, expensive, what are they called, analysis, then address us, we'll sue them. Yes, and it was a legal company who was taking part, as I understand, specializing in this type of in this type of cases. So, you know, I give this as an example for our students of how huge market failures are in this sphere. And they turned out, to my understanding, especially higher in the situation of pandemic. And that is, to my understanding, that is one of the explanation of the absence or of the reversed link between the level of financing and the results in this particular situation. And of course, the applicability of that index, which Tatiana was saying about, and certainly it doesn't work, or it worked just upside down, so to say, in this situation. So that's why I believe that all of us, we do understand that quite significant changes have to occur in this area, though, and I felt that Tatiana was not quite convinced what whether well, everybody understands that they are needed, but this is not a guarantee that they will take place. That's how I understood Tatiana, and probably we'll see it in future. Yes, Jamie, you're welcome.
Just, I think Tatiana Chilbadarova made the point that this is the distinction between a healthcare system run as a matter of business management and one run as a matter of public administration. We are very far down the road of a business management system, and it does cater in an expensive way to a whole set of let's say, expensive medical conditions for which one gets elaborate treatment, and that's where, of course, a very large share of the costs are. But it's unrelated to what one would do to manage the health of the whole population on a public interest basis in the face of this kind of a threat. And that's why there's such a large, let's say, lack of relationship between the expenditures and expenditures per capita and the ability of the system to handle something of this particular nature. It's very good if you happen to have a rare cancer, right? If you need neurosurgery, you know, the system will deal with you in an expensive, but so far as there are treatments for that sort of thing, effective way. But that's on a one-person case-by-case basis, small numbers of people at very high cost.
Right, thank you. Thank you, Jamie, for your comment. Yes, dear colleagues, would like to put questions or make comments. I don't see all of you, so please tell me just that you would like to do.
May I say a few words?
Yes, please. Please, Mikhail.
Well, I think that this comparison between the United States and other countries misses one important point, that the United States was fighting another war. This was not a war against pandemic, but actually they are investing a lot of money into medical research, and the technologies that they develop are used in other countries and are the most advanced and the best technologies that we know. I'd like to remind you that our former president, Mr. Yeltsin, invited DeBakey to operate on his heart rather than allow it to be done by our own doctors. Renat Akhturin was actually there, but DeBakey was presiding over the operation. So the technological and research and development in medicine is what we actually use all around the world, and the United States actually invests a lot into it. But they are, of course, this research and development will bring about a vaccine. I'm sure about that. They will soon. Johnson & Johnson will provide us with vaccines. Like in the past, they provided us, the Soviet Union, with the vaccine, with a live vaccine against poliomyelitis. That was an American vaccine that was used in the Soviet Union. But the point is that this is another war. This is a war that requires, as James said, mass treatment, and that's what the American system is not tuned into. They are not very good at it.
Yes, thank you. Thank you for a comment. Yes, colleagues, you are welcome. No more questions or comments? I don't see raised hands. Okay. Then let me say a few words. First of all, of course, thank you very much, Tatiana, for your presentation, and thank you everybody who took part in this discussion. It was really very interesting. And I should say that we've been working for how many? For 3 months, beginning from April 4. And so this is our last seminar, at least before the summer break. And I should say that as far as I am personally concerned, I was quite happy and glad to see all of you every Tuesday, and we had, I believe, very interesting discussions, and we have had 16 presentations, very interesting presentations. Our main speakers, their attitude was extremely serious to our seminars, and I thank all of you for this. And you know that the materials of our discussion, they are all posted on the site of Moscow School of Economics, and you can always find there the presentations, and also all our seminars were recorded. Unfortunately, we had a problem with one seminar, that's quite true, but 10 seminars, and I hope this one, the 11th seminar, will be on YouTube, so their general access is secured to this material. And I think it's very important what we've been discussing, and I believe that all of us we have gained from this discussion. And I am sure that our personal ties also have strengthened due to these unfortunate circumstances of COVID pandemic. And so now I would like to once more to thank all of you, and to wish you take care of yourself. And probably, I'm not sure, but I would like to think that this is possible. Probably we'll find a topic for our discussion in autumn, and Moscow School of Economics. We will be happy to host such another discussion, because I think that this one was very interesting and gave birth to many productive ideas, fruitful ideas. Thank you, all of you. Thank you. Take care. Thank you.
Thank you. Thank you.
Bye.
Thank you very much. Thank you. Bye-bye.
Спасибо большое, Саша. Спасибо большое все.
It was your initiative.
Очень интересно. Прекрасно.
Thank you.
Thank you.
Татьяна, если вас интересуют мои слайды, то свяжитесь со мной, я вам их скину.
Да, пожалуйста, пожалуйста.
By product.
Да, пожалуйста.
Until we meet again.
Yes. Bye.
Спасибо.
Всего доброго, спасибо.
Всего доброго.
До свидания.
До свидания.
Very good, Sasha. Excellent work. It's really been great.
Да.
We resume after the break.
Yes.
Take care of yourselves.
Thank you. Thank you.